Good morning, and I'd just like to start by congratulating the organisers for putting together a very exciting programme, and I look very much forward to interacting with many of the younger scientists in the audience over the next couple of days. So what I'd like to do over the next few minutes is really just to give you a personal story of a journey that I guess that I've been through over the last year, and it's a journey really that describes how an academic, a non-clinical academic, which is me, sat here at my desk, who normally lives in a nice cozy office in Cambridge. This is the biomedical campus, working on viruses that cause gastroenteritis, ends up spending somewhere in the region of 5 months dressed like this, working in an insect-filled tent as part of the Ebola virus response in Sierra Leone. Now, as you've heard already, the Ebola virus epidemic that is currently and still ongoing in West Africa is the worst that we've seen, and we've seen levels of intense human-to-human transmission that have not been recorded. The best estimates would suggest somewhere in the region of 28,000 suspected or confirmed cases so far, with approximately 11,000 deaths which have been attributed to Ebola virus infection. The good news is that actually the outbreak looks like it's largely under control in at least 2 of the affected countries, but sadly there are still cases of human-to-human transmission ongoing in at least 1. Now, this is an epidemiological trace of the number of cases across the outbreak from the start, from the first confirmed case in March 2014 until relatively recently. And as you can see, the peak of the epidemic was in October last year. In July and August of last year, I made a decision after close consultation with my wife that I would like to step forward and volunteer to help with the response. And I should say that as a non-clinical academic, the pathway from Cambridge to Sierra Leone was not straight. There wasn't an obvious path for someone like myself to be able to step forward and help in this outbreak. But eventually, as I'll describe over the next series of slides, I was deployed initially in November to establish and run a diagnostic facility, one of the first diagnostic facilities in the northern districts of Sierra Leone. I spent a period of around about 2 months there in total, and then subsequently from April until recently, and this laboratory is still running, we established a next-generation sequencing facility within Sierra Leone to provide in-country genetic sequencing of Ebola viruses. So, as I said, I was being deployed as a team leader with Public Health England and also by International Medical Corps to work in an Ebola treatment centre in Makani. This was one of the largest treatment centres, and in fact the treatment centre is still operational. They're going through a decommissioning process as we speak. This is the plan of the treatment centre as we were told that we would be greeted by. It's split into 3 zones. You have the red zone where the patients stay, the green zone which is largely where we work, and the white zone which is largely administrative. This is where the laboratory was located, which bridges the red zone and the green zone. And for those of you who don't know where Makani is, this is Makani. It's in a slightly northern area of Sierra Leone. It's a beautiful place. If any of you ever get an opportunity to visit, I do suggest it's a wonderful place to live and a wonderful place to work. When we turned up, the situation on the ground, I won't dwell on this image for too long, but just to highlight that the situation in Makani at the time of our deployment was pretty desperate. The healthcare, this is an article taken from the New York Times, which really illustrates what the situation was like on the ground. But just to suffice to say that it was a very desperate situation. The healthcare providers were completely overwhelmed, and there was a real urgent need for treatment facilities as well as diagnostic capability. And in fact, the lack of diagnostic capability at that time really contributed to the intense spread of the virus, because it was taking anything between 4 to 10 days in October for a patient to be tested positive or negative. So we were deployed to Makani. When we turned up, this is what we were greeted by. It wasn't built. The laboratory was still under construction. The outside of the shell of the laboratory was established, but the rest of the treatment center was largely still under construction. So, as you can imagine, the first few weeks we faced a number of challenges in trying to establish the laboratory, establish the workflow, and get the entire process operational. This is our team. This is me. We had a relatively small team of 10 scientists, some from academic backgrounds, most of them from clinical backgrounds or diagnostic backgrounds. What you can see quite clearly here is we are not designed for manual labor. The most energetic thing I would do in my day is moving papers from one side of my desk to the other. However, in the first week or two, our job was there simply to move equipment around the treatment center, and we had 3 lorries like this turn up, all of which had to be manually offloaded by ourselves and packed into tents, and inevitably there were various injuries. But the team, I think the team pulled together and we did pretty well. We then spent the next week or two trying to build the equipment, trying to make sure everything was intact, everything worked. Of course, logistics being as they are, some things didn't turn up. In the cases when things didn't turn up, we had to go to the market to try and buy stuff. We had to try and make things that would do the same job. This is me with a piece of tape stuck to my forehead. But the end result was that we were able to put together a diagnostic laboratory as shown here. This is the opening on December the 13th. This was later than we'd hoped, but everybody was pushing and pushing in the right direction, but this was simply due to the resources not being in place. Some of our equipment hadn't turned up, but we officially opened. Our first samples were tested on December the 13th. Now this lab is still operational. It continues to operate at the minute. They've tested somewhere in the region of 15,000 samples so far. And the workflow looks something like this. A sample would turn up from usually by a bike courier, and these samples include blood or swabs from patients that have passed away. They're handled by somebody like myself here in nice orange Crocs. We take them into what's known as a flexible film isolator, which enables us to work with the virus under controlled conditions to minimize the risk of infection. An aliquot of that sample is then taken, and the infectivity of the virus is neutralized using chemicals. The sample is then taken out of the flexible film isolator and the nucleic acid extracted prior to detection of the viral genome by real-time PCR. As I said, this lab is still operational, and I spent 2 periods of deployment over the last 12 months. I spent 2 months here running this laboratory. There were numerous challenges that we faced, as I said. One of the challenges, I live in Cambridge. We do not encounter spiders the size of your hand roaming around the laboratory. So getting accustomed to this sort of thing on a daily basis it took a slight period of adjustment. But the biggest challenge was, of course, the reality of the situation. As I said, I'm a non-clinical academic. I have no contact with patients whatsoever. The location of the laboratory and the workflow of the treatment center meant that we were witnessing on a daily basis quite desperate events. And what we would see, certainly for a parent such as myself, I have 2 young children, we'd often see individuals such as these guys come in on their own. They're cared for by survivors, and you will either see them progress through the disease and come out as survivors, or unfortunately pass away. It was not, despite what happens in an Ebola treatment center, I would say that myself and almost everybody who's worked there would feel that actually it's a very positive environment to work in. The overwhelming feeling you get there is that the national staff, so the Sierra Leoneans and the international staff, are there to do their best. They all work together, and it's a very happy environment. And in fact, what you'll find is that, turn that down, that when a survivor is discharged, it's usually accompanied by a lot of dancing. Bad dancing on the behalf of the international staff. I think we learned a lot in our time in the treatment center. But it was a very joyous occasion, and in fact, this is one of the things that spurs the team on and can boost morale when things get particularly bad. Now, as I said, I've been there 5 times now. In my first deployment in December 2014, one of the things we identified was that there was a real need for in-country genetic sequencing capabilities. At the time, we had very little information about how this level of intense human-to-human transmission of Ebola virus was affecting the evolution of that virus. And in fact, there was very little sequence data available. And the sequence data that was available was being released in a time frame that made it almost worthless to the people on the ground. So samples were being collected, shipped out of the affected countries, sequenced, and then the data being released. And it was typically in the region of 4 to 5 months from a sample being taken to the data being available to the epidemiologists. So we took the approach which was to basically move the equipment and the associated infrastructure to the Ebola treatment center to bring this time frame down and to be able to provide real-time sequencing capabilities of the viruses as they came out of the patients. This was enable us to identify and confirm epidemiological links. So as I'll illustrate, where patients who were tested positive, who had no known source of infection, we were able to link them to known and previous transmission chains. We could understand virus evolution, and of course we could also confirm that this level of repeated human-to-human transmission was not compromising our ability to detect this virus. In January, I think there was approximately 15 laboratories, at least 15 laboratories operating in Sierra Leone alone, all using slightly different tests, and therefore it is possible that this level of repeated transmission could have compromised our ability to detect the virus. And by providing real-time sequencing, we were able to at least check how the virus was evolving during the epidemic. The last and equally important was, in fact, to use this infrastructure in the longer term to provide Sierra Leonean scientists with access to these cutting-edge technologies to allow the characterization of infectious diseases. And this is something I'll touch on briefly at the end. So I arrived home on the 23rd of December. My Christmas period was spent applying for grants and contacting suppliers. And in February, we were awarded a grant by the Wellcome Trust, and there was a frantic period of trying to find suppliers who would ship equipment to us fast enough, training on equipment. I had never run a sequencer in my life. This was my first experience. And in my third deployment in April and May 2015, we went off to establish a sequencing facility in this tent. This is a storage tent which is next to the diagnostic laboratory in the Ebola treatment center. Thankfully, the lorries turned up, and this is a video of myself and my postdoc. We don't normally move this fast, but what you can see is us building the associated pieces of equipment, unpacking them, and eventually we got around to testing them. If you slow this video down, you can see us have a big cheer at the end. I think simply from the relief that all this equipment had turned up intact, on time. So the end result was that we had a sequencing facility in a tent in Sierra Leone. We had PCR hoods, which enable us to work with the nucleic acids to keep the dust out of them. We had a liquid handling robot, enables us to process the samples, and the sequencer itself, which enables us to provide, to characterize the viruses. And this is Armando. And we've been rotating people out now since, I think since early April, and we've been operating the sequencing as a part of the Ebola response. I don't have time to go into a lot of the data, but I'll quickly go through some of this. We've processed in excess of 1,200 clinical samples for sequencing now. This has yielded over 600 full genomes, most of which we make freely available to the scientific community for analysis. The vast majority of the samples have worked well, so our workflow is robust, and thankfully our machines haven't broken yet. We have our turnaround time from sample receipt into the laboratory to the full genome assembled and given back to the Ministry of Health and the various agencies down to, at best, 24 hours. Generally, it's 2 to 3 days. And we're now embedded into the Ebola outbreak response, whereby any new samples identified in Sierra Leone are brought to us, and we sequenced and an epidemiological report produced and given to the ministry and the various other agencies that are involved in the response. This sequencing data, I don't want to go into the details here, but this has really provided us with really unprecedented understanding of virus evolution. And what we can do is we can identify transmission chains. Each one of these long lines is an individual transmission chain. We can see when transmission chains are continuing, and we can also see when a transmission chain has ended. And we can see how implementation within for example, border control played an important role in breaking a number of these transmission chains. And the ability to sequence these viruses in real time in country has provided, it's become increasingly important during the epidemic endgame. And I'd like to just illustrate this with the last case that was identified in Sierra Leone. We can take a case that has no known source of infection and link it by simply sequencing the viruses to a previous chain of transmission. The last case was a 16-year-old girl from a village near Makani, and that village had in fact been completely free of Ebola virus for many, many months. She reported ill on the 7th of September, transferred to the Ebola treatment center on the 12th, and subsequently died. We were able to sequence those samples within a 24-hour period, and we were able to show that the closest match was in fact from the same village from the previous year, November and December 2014. And this is very crudely illustrated here. This is the patient sample, and these are two samples that we sequenced from the same village from November and December. So the most obvious conclusion from this was that this event, this infection, was due to a transmission from a survivor. And we've been involved in a number of cases similar to this where we report this information immediately back to the ministry. So what are our future plans? Well, we've spent all this time, effort and money in getting all this equipment and resources to Sierra Leone. What do we do with it when the epidemic is over? So our plan, and what we have done as of the middle of September, is to move all our sequencing facility to the local university. We're working with the University of Makani, UNIMAC, and we're based in this building. This is the Yoni campus. This is the president's hometown. I think, in fact, he owns this house. But this is our laboratory. And we've established an infectious disease research laboratory. These are some early pictures. I'll show you some others in a second, where we have two containment level 2 facilities where we can work with infectious diseases. And we have a relatively large molecular laboratory where we can perform sequencing and molecular work. And the aim is to use this as an infrastructure to train national staff in molecular methods, but also to provide a platform for international and national staff to undertake infectious disease research. And this is just a number of pictures of some of the other rooms in the facility. If anyone is interested in working out here, please come and see me. We are more than willing to accommodate people. We can give access to all this equipment free of charge. Many of the reagents are already in place. And as you can see, we've employed a number of locals in the university. We're working together to provide a sustainable infrastructure. What I'd like to do is really just finish by acknowledging the people involved in the work, and of course, funding from the Wellcome Trust. This is one of my favorite pictures from my time in Sierra Leone because it shows that, you know, we're all very hot and sweaty, but in fact, we had a fantastic time, and I look forward to going back there and hopefully working with some of you in the audience. Thank you.